Hello everyone. Welcome back to the series of lectures in endocrinology. So we were discussing about the adrenal gland. Today we will talk about the tumor of a very important tumor of the adrenal gland, which is your pheochromocytoma. So let's begin. So what is this pheochromocytoma? Pheochromocytomas are basically catecholamine producing tumors which are derived from the sympathetic or the parasympathetic nervous system. So they are catecholamine producing tumors which arise from the sympathetic or the parasympathetic nervous system. So the most common site of your adrenal pheo, is that it arises from the medulla. The pheochromocytomas which can arise from extra-adrenal parts are what we call as your paraganglionomas. So extra-adrenal pheos are called as paraganglionomas. They are called as paraganglionomas. Okay. And what are the hormones which they produce in excess? This is nothing but your catecholamines. So what are catecholamines? The catecholamines that they can produce are epinephrine, norepinephrine and dopamine. Okay. So the most common catecholamine that they produced is epinephrine. Apart from this, they can produce norepinephrine and dopamine as well. Norepinephrine are more commonly produced by your paraganglionomas. Dopamine is more commonly produced by your malignant pheochromocytomas. Malignant pheo is also called as metastatic pheochromocytoma. Okay. So basically, pheochromocytomas are catecholamine producing tumors which arise from the adrenal medulla. Now, let us look at the location. So the most common site is the adrenal medulla. Apart from that, extra-adrenal pheos can arise from the sympathetic trunk, parasympathetic carotid body, glomus jugulare or glomus vagal. Okay. So these paraganglionomas can so arise from the skull base and the neck. So if you see these images, can you see that this is an adrenal pheo? So the other locations where these pheochromocytomas can arise from, this is in your carotid bodies. This is your carotid. Okay. Then you can also have your thorax. They can arise from the thorax. They can arise from the abdominal ganglia. Okay. They can arise from the para-aortic abdominal ganglia. This is your bladder. So they can arise from your urinary bladder as well. So this is about the various sites in which you can have your pheochromocytoma and your paraganglionoma arising from. So what are the germline mutations associated with pheo? So the germline mutations with which pheochromocytoma can be associated is your RET gene. Then you have your VHL, which is your von Hippel-Lindau gene. Then NF1, which is neurofibromatosis gene, succinate dehydrogenase gene and hypoxia inducible factor. So depending upon what genetic mutations are involved, pheochromocytomas can be classified into clusters. These clusters include first your pseudo-hypoxia cluster, which involves your HIF gene. Then you have your kinase cluster, which involves your RET or NF1 gene. Then you have disorders of your WNT signaling group or genetic mutations in your WNT signaling group. So this is about the different genes that can be involved in pheo. Okay, so based on your genetic mutations, you can divide them into clusters. Pseudo-hypoxia cluster, WNT signaling cluster and kinase cluster. Fine? Okay. So what is the rule of 10 in pheochromocytoma? There's something that you should be aware of is the rule of 10. So what is the rule of 10? 10% of the pheochromocytomas are bilateral in nature. 10% of the pheochromocytomas are bilateral in nature. Another 10% of the pheochromocytomas can be malignant. 10% of the pheochromocytomas can be malignant. 10% can be familial or syndromic. 10% can be familial or syndromic. And 10% of the pheos are seen in children. They are seen in children. So this is your rule of 10. 10% can be familial, 10% can be bilateral, 10% can be malignant, 10% can be seen in children. But now this 10% rule does not really hold good. Up to 25% of the pheos can have a genetic association. That's why after the discovery of these genes and these clusters, we can see that up to 25% of the pheochromocytomas have a familial association. Okay, fine. Now, before we move on to the clinical features, let us understand a last point. What is the pathological features of Pheo? What are the pathological features of Pheo? So, pheochromocytomas basically arise from the neural crest cells. They arise from the neural crest cell. So, what you see is a pattern on the histopathological examination which is called as the Zell-Belen pattern. Okay, so you have sheets of neural crest cells, which are arranged in your Zell-Belen pattern, and this is surrounded by your vasculature. Okay, and what are the tumor markers which it can be positive for? It can be positive for neuron specific enolase. So it can be positive for your NSE and chromogran. So that is about the pathology. Okay, so clear till here? So what have we looked at? Pheochromocytomas are catecholamine producing tumors. We have looked at the sites. We have understood the 10% rule and the germline mutations which can be seen associated with Pheo. Okay, now let us move forward. Let us look at each of these clinical features of pheochromocytoma and why does it happen. Let us look at each of these clinical features and why does it. So, pheochromocytoma is basically the basic pathology which happens here is due to excessive production of catecholamines. So, there is excessive production of catecholamines. So, what is the main issue with this catecholamines? Catecholamines we know are a positive ionotropic agent. They are a positive ionotropic agent. So, the most common effect of this catecholamines is most prevalent, or the most prevalent effect of this catecholamines is on the cardiovascular system, on the heart. So, in the heart, this basically causes increase in the contractility of the heart. It causes increase in the contractility of the heart, resulting in an increase in the heart rate. There is an increase in the contractility of the heart, resulting in an increased heart rate. Apart from that, what happens is that it is responsible for peripheral vasoconstriction. It is responsible for peripheral vasoconstriction, causing an increase in the systemic vascular resistance as well. There is peripheral vasoconstriction, increase in the systemic vascular resistance as well. So, on the whole, what happens? All of this basically results in an increased blood pressure. There is an increased blood pressure. Alright. So, let us look at the first and the most common symptom is that they present with headaches. Okay. So, why does pheochromocytoma present with headaches? Because of this increased blood pressure can result in headaches. Okay. Fine. Let us look at the next most common symptom. They can have profuse sweating. Why do they have profuse sweating? Though these pheochromocytomas arise from the sympathetic nervous system, there can be blunting. There can be blunting of the sympathetic reflexes. There can be blunting of the sympathetic reflexes. Also, your peripheral vasoconstriction can cause profuse sweating, right? Third symptom, palpitations and tachycardia. Why? Catecholamines effect on the heart. It can cause increase in the heart rate, resulting in palpitations or tachycardia. Then, hypertension. 60% of the individuals present with sustained hypertension or refractory hypertension, refractory to up to 2 to 3 groups of antihypertensives. Okay, 40% of the individuals present with paroxysmal hypertension, where sometimes the BP will be normal. When the catecholamine release is more, then the BP can shoot up. So, they can be sustained or paroxysmal hypertension. Okay. Then, this kind of sympathetic overactivity can cause or simulate a panic attack because the patient appears very anxious. The patient appears very anxious. There's a lot of sweating and can simulate a panic attack. Next symptom is pallor. Why is there pallor? Again, because of peripheral vasoconstriction. Because of peripheral vasoconstriction, there can be pallor. The patient appears very pale. Fine. Then, nausea, abdominal pain, generalized fatigue can be there. So, the hallmark clinical features that you have to remember with respect to pheochromocytoma is your hypertension, headache, palpitations and sweating. Hypertension, headache, palpitations and sweating. Now, let us look at the other symptoms. So, there can be an associated weight loss. Why? Because catecholamine causes an increase in the basal metabolic rate, and apart from that, in metastatic Pheo or malignant Pheo, you can have weight loss. Okay, fine. Then there can be a paradoxical response to antihypertensive drugs. That is because the catecholamine secretion can occur independent of what antihypertensive you are giving. So, they can be a paradoxical response to antihypertensive drugs. Then, polyuria and polydipsia. These catecholamines basically have an inhibitory effect on ADH. ADH is your antidiuretic hormone. Antidiuretic hormone basically inhibits diuresis or prevents excessive water loss. So, what happens is that here there is an inhibitory effect on the ADH. Because of this, there will be an ADH deficiency. So, that will result in your polyuria, polydipsia, similar to your diabetes insipidus. Okay, fine. Then, next symptom we will look at orthostatic hypotension. So, what is orthostatic hypotension? Now, this patient is recumbent. When you make the patient stand up, the blood pressure falls by systolic blood pressure more than 20 millimeters of mercury, diastolic blood pressure more than 10 millimeters of mercury, and the heart rate increases by more than 30 beats per minute. So, this is your 30-20-10 rule in your orthostatic hypertension. So, whenever there is orthostatic hypotension, patient is initially recumbent, you check the BP, then you ask him to stand up and check the BP after 1 minute and 3 minutes. The systolic blood pressure falls by more than 20, diastolic blood pressure falls by more than 10, and the heart rate increases by more than 30. This is your orthostatic hypotension. Okay. So, why is there orthostatic hypotension in Pheo? Mainly again because of blunting of your reflexes. There is blunting of your sympathetic reflexes, and there is some amount of volume depletion as well. There is volume depletion as well because of your inhibitory effect on ADH. There will be volume depletion which can cause orthostatic hypotension. Then, chronic hypertension can result in dilated cardiomyopathy. It can result in dilated cardiomyopathy because the heart is functioning at a higher rate. It is functioning against a higher afterload a long time, which can result in DCM. Then, why is there erythrocytosis? Again, because of the decreased plasma volume. There is a decreased plasma volume. There is an increase in the hematocrit resulting in erythrocytosis. Okay. Then, elevated blood sugar. Basically, catecholamines basically have an anti-insulin action. Okay, catecholamines can have an anti-insulin action. Now, the main aim of insulin is it decreases the blood glucose, right? So, because catecholamines have anti-insulin action, this is going to increase your glycogenolysis and gluconeogenesis, and hence you will have increased blood glucose and elevated blood sugar levels. Very important. Very importantly, your pheochromocytoma can have associated hypercalcemia because of your paraneoplastic feature or associated with other multiple endocrine neoplasia syndromes. They can have hypercalcemia. This hypercalcemia in essential itself can cause your polyuria and constipation. It can cause polyuria and constipation. Okay, so clear? So, this is about the various clinical features of pheochromocytoma and why it is happening. Okay, fine. Now, let us move forward. So, how do you diagnose your pheochromocytoma? So, biochemical testing is the most important testing that you have to do for diagnosis of Pheo. So, biochemical testing. So, what do we check in this biochemical testing? We do not look for the catecholamine levels. Though this is a catecholamine producing tumor, catecholamine levels is not very preferred. What we actually check for is your metanephrine levels. Okay, so what we see is a 24-hour fractionated urinary metanephrine levels, which has a very high sensitivity. Though total metanephrine levels can also be checked, but what we check is your fractionated 24-hour metanephrine. So, this screening test which is used for the diagnosis of Pheo is your 24-hour urinary fractionated metanephrine levels. Okay. Apart from this, the plasma tests include a free plasma metanephrine levels, which again has a high sensitivity and specificity. Okay, which includes a high sensitivity and specificity. Now, apart from your biochemical diagnosis, you may also require an imaging to localize your pheochromocytoma. So, to localize your pheochromocytoma, the tests that we do can be a CT and MRI. The CT and MRI are sensitive, but their specificity is quite low. So, though they are sensitive in picking up a tumor, you cannot really know whether this is a Pheo or not. Okay, so newer tests which are being done is your radionuclide tests, which are used for the diagnosis of Pheo. So the tests which are used, which is highly specific, is your MIBG scintigraphy, which is the very specific test. Then you have somatostatin receptor scintigraphy. But what I would say the most sensitive and most specific test which you use is your fluorodopa PET-CT or gallium dotatate PET-CT. So your gold standard for your diagnosis of Pheo is your gallium dotatate or gallium dotatate PET-CT because of its high sensitivity and specificity in the diagnosis of Pheo. Because of its high sensitivity and specificity of more than 95% in the diagnosis of Pheochromocytoma. So the best screening test will be a 24-hour urinary free metanephrines, and the best or the gold standard test will be your gallium dotatate PET-CT. Okay. So the problem with these biochemical tests is that you can have false positive values with drugs such as levodopa, sympathomimetics and beta blockers. So it's very imperative that you stop all these drugs before you do a screening test for Pheo. Okay, fine. Now let us look at the pathology. The pathology we have already learned. There can be nests of neuroendocrine cells surrounded by sustentacular cells, which we call as the Zalbelin pattern. Immunohistochemistry, the chief cells will produce synoptophysin and chromogranin. The sustentacular cells will produce S100. So these cells, if on your histopath, if these cells are positive, then you can do a definitive diagnosis of Pheo. What are the differential diagnoses? The differential diagnosis, because of this paroxysms of hypertension, palpitations, profuse sweating, they can mimic a panic attack. They can also mimic mastocytosis and carcinoid, where you can have flushing and sweating similar to your Pheo. Okay, fine. So this is about the pathology and diagnosis and your differential diagnosis of Pheochromocytoma. Now let us look at the treatment. So the most important clinical feature which has to be immediately addressed is the management of blood pressure. Though we know that the final treatment for Pheochromocytoma will be removal of the tumor, but the blood pressure has to be brought under control before the patient goes for surgery. Because if you meddle with the tumor during the time of surgery, you can precipitate a hypertensive crisis. If there is a hypertensive crisis, you can precipitate an MI, you can precipitate a stroke. So, perioperative management of blood pressure becomes very important in your Pheochromocytoma. The first drug that we use is your alpha blockers. So, you ensure that the patient has adequate alpha blockade. So, the drug which is used is oral phenoxybenzamine, which ensures that there is adequate alpha block. Now, because these Pheochromocytoma patients are volume depleted, you ensure that there is a liberal fluid intake. Okay. So, once these Pheochromocytoma patients are admitted, you do a proper blood pressure monitoring, ensure liberal fluid intake, make sure that they are volume depleted, start them on alpha blockers. How do you assess for adequate alpha blockade? The patient will have orthostatic hypotension and blood pressure also comes under control. Now, once that is done, then you initiate them on beta blockers. Will you initiate them on beta blockers before initiating on alpha blockade? No, because if you initiate beta blockers before initiating alpha blockade, there can be unopposed alpha action. This unopposed alpha action can worsen the blood pressure. That is the reason why you first cause alpha blockade, then you cause sequential beta blockade. Beta blockers can be brought about by non-selective beta blockers like propranolol. Okay, so this is how you ensure that the patient's blood pressure is adequately controlled, and then you take them up for surgery. Now, during the surgery, when the surgeon is operating, sometimes you can precipitate an hypertension crisis. Hypertensive crisis, and the drug of choice during a hypertensive crisis in this case is your IV nitroglycerin. It is your IV nitroglycerin. Okay, so if there is a hypertensive crisis during your surgery, you give them IV nitroglycerin, NTG infusion. Then, what about the treatment of metastatic Pheo? Metastatic Pheo, the treatment is your iodine 131 MIBG, 3 to 4 cycles, which is used for the treatment as well, not only the diagnosis. So, this is your nuclear treatment or your nuclear medicine treatment for metastatic Pheo. Apart from that, certain other regimens are used. For example, your Averbrook regimen. In your Averbrook regimen, you use multiple drugs or multiple chemotherapy for the management of metastatic Pheo. So, the drugs that are used are cyclophosphamide, vincristine and dacarbazine. Okay. So, this is one chemotherapy regimen which you can use for metastatic Pheo. Fine. So, this brings us to the end of the session on pheochromocytoma. So, what have we learned? So, we have learnt about pheochromocytoma, we have learnt about paragangliomas. Then we have learnt about the various clinical features with which they can present. We have understood the pathology, we have understood what are the most sensitive tests used for diagnosis, and we have learnt about the management as well. So, this brings us to the end of our session on the series of lectures about the adrenal gland as well. Thank you.